I am Dr. Rama Krishna Chaitanya, your anesthesia faculty. So I have been teaching anesthesia, practicing anesthesiology since 15 years. And recently I made some videos on the marrow SS also. So the basic core concepts of the anesthesia, right? So what we plan today is, because as the exam is coming and the new edition of Miller has also came into the market. So I thought why don't we do a small kind of a webinar where we will discuss the basic concepts, because of late, no one knows exactly how questions are going to be framed in your entrance examination. But as per the last year question paper or before last year question paper, most of the times the questions were at the basic level only, and that too at a very standard level question of asking the questions have been there in your entrance examination. So what I thought was, let us do a small MCQ based discussion, so that 1 hour discussion, so that this will be useful for you. You will understand some points. You can answer these questions, and it will be like slight brush up topic for you. 1 hour, so you can just listen to it. If you know the answer, you can tell it, or if you don't know, also I made it very simple. So I don't want to create a FOMO just before the examination, putting some weird or vague questions which are not asked, or some fancy questions. So basic set of questions I have made. That too, I'm taking the reference as Miller 10th edition, because the new edition is came into the market. Okay, so with this, shall we start the first question? Right. So what is there on the screen? What is the first question? A 36-year-old female is posted for ovarian cystectomy. The patient has a history of significant muscular weakness, stiffness with painful spasms associated with vision as well as bladder problems, which are present for a certain period in a year, following which these symptoms are resolved spontaneously. At present, the patient is completely symptom free. The best anesthesia technique would be, right, whatever the diagnosis you are making right now in your brain, you can drop it in the chat box so that I can see. A very common scenario you might encounter during your clinical practice, and this kind of questions might attract the examiners in creating the MCQs. So I'll read out the question one more time. Whatever the option you are thinking, please drop down the answer there in the chat box. So there are around 69 students. You can drop it freely. I'm not going to judge anyone. So 36-year-old female is there, posted for cystectomy. So she has a past history significant for muscular weakness, stiffness, and painful spasms associated with vision as well as bladder problems, which are present for certain period of time. Now, right now, she is asymptomatic. Chat disabled. I don't want to answer. I just want to know what is the diagnosis. Someone has messaged, Rima George has messaged combined spinal and epidural anesthesia. Good. Yes. Is the chat enabled? I can't see any answers. Chat is myasthenia gravis. So she was, it's myasthenia gravis. Okay, not myasthenia gravis exactly. Not myasthenia gravis. Muskan Ramtree. Dr. Muskan has said myasthenia. Any other option? See here, this is very common scenario. So all three. Dr. Preeti, multiple sclerosis. Yes, very good. Multiple sclerosis, right? Yeah, exactly. So, making diagnosis is very, very important for this kind of MCQs. Now, this is a classical case of multiple sclerosis. In multiple sclerosis, what is multiple sclerosis? It's a chronic progressive neurological disorder where there will be damage to your myelin sheath. As the myelin sheath is damaged, there might be exposure of your nerves directly, right? So exposure of the nerves directly. Whereas in myasthenia gravis, the presentation will be very different. So the patient will complain of muscle weakness only. There is no associated autonomic dystrophy, right? So what happens in myasthenia gravis is there is no symptom-free period in myasthenia gravis. Whereas in multiple sclerosis, you will definitely have a symptom-free period, because the disease progresses in a very different fashion, right? So there will be an initial relapsing and remitting phase, followed by sometimes there will be completely symptoms, then followed by completely symptom freeness. Sometimes the disease might progress like primary progressive, where the diseases go on progressing. The second one is secondary progressive disorder. Right now, in this kind of diseases, myasthenia gravis is having weakness that is present throughout the day without any weaknesses, and there is no autonomic involvement. Now, tell me, how are you going to rule out any other muscular dystrophies? Any muscular dystrophies? Why don't it is be a muscular dystrophies? Why not it is a Eaton-Lambert syndrome? Why not it is an Eaton-Lambert syndrome? Any clue? Yes. Any answers? Yes, multiple sclerosis. Everyone said myosclerosis can use GA with train of four monitoring. Wonderful. Multiple sclerosis. Yes, I'll tell you. So myasthenia gravis, what will happen? The symptoms will become weaker, and as the day progresses, the patient will become weaker and weaker as the day progresses. Right. So after a rest, again the muscle will gain. But whereas in any muscular dystrophies, what will happen is there will not be, yes, in muscular dystrophies, the symptoms, yes, not worsening with exercise is Eaton-Lambert syndrome. Autonomic involvement is multiple sclerosis. Whereas in Eaton-Lambert syndrome, what will happen is the disease will not be progressive, right? So there is an entire different pathology will be there. Right now, what is the answer? It's a simple case of ovarian cystectomy. What does you want to choose? So classically, someone said rightly, yes, combined spinal epidural, or which is the best option? One of the relative contraindication for regional anesthesia is any progressive neurological disorder. Right. So if you are planning to take this case under progressive neurological disorder, yes, doing spinal anesthesia itself might be a bit riskier. Why may be a bit riskier means, patient might have worsening of the symptoms. Yes, there are some reports which have been said that spinal anesthesia is safer, but not yet standardized in Miller textbook. There are some reports or some cohort studies they have made in the pregnant ladies, and they found out that using of regional anesthesia will not worsen the symptoms. But they have not yet mandated in this. So any kind of regional anesthesia, unless and otherwise it is not. Suppose if they say it is a difficult intubation, then, or you might say that the patient is allergic to some drug or Rocuronium, something like that drug, then only if there is a specific indication, then only go for regional anesthesia. It's always better to stand on the safer side. So here it has nowhere it has been mentioned, and most of the examiners also think that better not to go with any kind of regional kind of anesthesia. So we'll rule out two options. Option C and option D, we are going to rule out spinal anesthesia and combined spinal epidural anesthesia because of the fact it's not absolutely contraindicated. Again, I'm saying you the absolute contraindication for regional anesthesia are, as you know, it is raised intracranial pressure, bleeding disorders, or any what we call as local site infection, patient refusal. These are all absolute contraindications. We are talking about relative contraindications. In this relative contraindication, so better not to go with any regional anesthesia. Right. So which one you have to choose? General anesthesia. Why NDMR? Someone like Dr. Patika has said NDMR. Someone has said general anesthesia with depolarizing. So then comes again a tricky point. So examiner typically wants to ask you which muscle relaxant would you like to choose? Why? Is there any specific reason why some people, like one person has said, Dr. Pratika has said, Pratik, sorry if I am spelling it wrongly also, right? Why NDMR? Why not DMR? Right. As I said you, it's an autoimmune disorder. There will be damage to your myelin sheath. Because there is a damage to the myelin sheath, the response to this succinylcholine, which is a depolarizing muscle relaxant, will not be adequate. So you need to use NDMR. There is a chance of hyperkalemia when you use DMR, depolarizing muscle relaxants. So better to go with a non-depolarizing muscle relaxants only. But one precaution you need to do, someone said very rightly, train of four monitoring. I don't see which where. Yes, Dr. Swayam, Dr. Swayam Tara, Dr. Tara has said train of four monitoring. Why? Because there will be, varied response with this NDMR muscle relaxant. Right. So that's the reason why what is the correct answer in this MCQ? General anesthesia with endotracheal intubation using a non-depolarizing muscle relaxants. Better to avoid depolarizing muscle relaxants. So any muscular dystrophies, it's better to avoid all kind of depolarizing muscle relaxants. Any history which is suggestive, because nowhere in any point we are justified by giving any drugs like succinylcholine. And of late, what happened according to the Western literature, most of the people are using rocuronium. So no MCQ, if I'm not wrong, if you are suspecting any muscular dystrophy, take it from my side that you can, unless and otherwise there is a specific indication to use succinylcholine, you can easily avoid succinylcholine and go with DMR. So one precaution, what do you want to take? I don't know whether you have done this kind of cases. Increase its sensitivity. Yes, very good. Increase its sensitivity is the very important point. One precaution, what precaution you will take in these kind of patients with multiple sclerosis? Let us finish off this MCQ. What precaution you will take? Is there anything which special precaution you need to take with multiple sclerosis apart from DMR, NDMR, regional anesthesia, what we have discussed? Any other thing which we understood? Yes, one precaution which you need to take is you should avoid. Someone is messaging, yes, yeah, yes, very good. So you should avoid, or you should closely monitor the temperature of the patient. Why? Because any hyperthermia, again, it might worsen the symptom. Yes, very good. Dr. Parthasarthi has mentioned temperature management is a very important in case of multiple sclerosis patients. So this is the take-home point regarding the first MCQ, that is multiple sclerosis patient. Shall we see the second MCQ? Right. So just try to answer in this question and answer point. Then I can easily see that, right? Right. So yes, what is the answer for the second question? 100 kg person suffering from burn injury. What is the best muscle relaxant? He has third degree burns. Yes. In the chat screen also, D. Sir, succinylcholine. Yes. Succinylcholine. Right. Someone has said succinylcholine, right? Why not rocuronium? Right. Why not rocuronium? Or is rocuronium right option here? Rocuronium, is it right answer? Some people, yes, very good. Someone has measured, Dr. Vijay Raj has mentioned 1.2 mg per kg for rocuronium. Yes, 1.2 mg per kg rocuronium. Yes, what is the dose of rocuronium? Succinylcholine, rocuronium dose is not appropriate for rapid. Yes, very good. All of you have got it right. That's the reason why I said you basics should be very strong enough. Succinylcholine is the right answer. We will avoid succinylcholine. You might be knowing it. Any depolarizing muscle relaxants in case of burns, we will be avoiding this kind of depolarizing muscle relaxants from 6 days to 6 months, approximately 6 days to 6 months. What happens is the receptors will get changed. So after 6 days, the receptors will get changed, and usage up to 6 months, the receptors, there is a chance of hyperkalemia. So before 6 days, our priority is to select with a quick acting muscle relaxant, that is succinylcholine, at a dose of 1 to 2 mg per kg. That is 2 times effective dose 95 of succinylcholine. Actually, it is more than that what we are using. But yes, what we are using is 1 to 2 mg per kg of succinylcholine is the correct answer. Miller said 2 years. What to follow? Yes, recent Miller also, they have not mentioned very clearly, but 6 months, up to 6 months, you should avoid it. That is what it is said. Right. So up to 6 months, we don't know exactly how much period these receptors will be in a different format. So that's the reason why we generally say after 6 days, we will try to avoid it. Yes. This is on. Yes, this is the second question. Yes, that is. So now comes a very important question. I don't have an option of succinylcholine. You said rocuronium at a dose of what we call this, rocuronium at a dose of 1.2 mg per kg. Yes. Right. Rocuronium dose is 1.2 mg per kg. Now, I will ask you a very basic question. Why rocuronium is quick in onset? Don't answer the third question. Yes. Why rocuronium is quick in onset, like succinylcholine? Any answer? Why rocuronium is quick in onset? Why not? Why it is quick in onset? Any answer? Anyone like to answer? Yamini Arora also, Dr. Skolin, very good. Right. No, not lipid solubility. Any muscle relaxants are not lipid soluble substances. All muscle relaxants are water soluble substances. ED 95 is 33 times. No, we are using only 2 times ED 95 at 1.2 mg per kg. Any other? Rocuronium is a low potent molecule. At a dose, what we are using at 1.2 mg per kg, you will have plenty number of molecules that are available. So that's the reason why rocuronium is very quick in onset. Have you understood the reason why rocuronium is very quick? Rocuronium, out of all the agent, it has a low potent molecule. It requires a lot of molecules. That is the reason why now we are having rocuronium. When I was doing post-graduation, when succinylcholine is not is contraindicated, and if I want to quickly intubate a patient, what we used to do is we used to do high doses of rocuronium. Vecuronium at a large doses, like generally we take it around 0.1 mg per kg. But what we used to do is we used to give around 0.5 mg per kg and we used to intubate, but that's not a safest technique. So just I wanted to add this point. If you want to intubate with vecuronium or pancuronium, you need to use high larger dose. And what if you can't intubate in that situation? That's the reason why rocuronium has become very, very popular, right? And that too after Sugama Dex, it has become very, very popular. Right? Have you understood why rocuronium is very quick in onset? Right. So shall we move to the next question? So this is a very basic question which I wanted to add. So 2 mg of vecuronium followed by succinylcholine, 1 mg of vecuronium. At 1 mg, 2 mg, you cannot get very quickly, right? Now, is there any other way to quicken the onset? Is there any other way to quicken the onset by using vecuronium only, apart from rocuronium? I am not discussing about this MCQ. On a general note, I wanted to give you some information. Priming. What do you mean by priming technique? Yes, very good. What do you mean by priming technique? Priming technique is given in Miller's textbook also. This is an age-old technique. What we do is we give 1/10 of the dose of the actual dose what we are doing. No, pre-crurization. Yeah, that's also 1/10 of the dose is given. And after that, the onset will be very quickened so that you can get very quickly. So rocuronium is a good option, 1.2 mg per kg. If rocuronium is not available, succinylcholine is contraindicated, then only we have to go. Of late, they are not giving this kind of it. So just want to add this one. Okay, right? Shall we move to the next question? Yes, the next question is a otherwise healthy 4-year-old male patient is undergoing an elective tonsillectomy. Before induction of general anesthesia, the patient is breathing at a rate of 20 breaths per minute, and inhalational induction is begun with 8% sevoflurane, 50% nitrous oxide and oxygen. 60 seconds later, the patient is noted to breathe at a rate of 40 breaths per minute and heart rate of 160. This rapid respiratory rate with tachycardia most likely represents excitement stage of anesthesia. Very good. Excitement stage. Everyone is mentioning excitement stage. Yes, excitement stage. Why not it is malignant hyperthermia? How do you identify malignant hyperthermia? Again, this is one of the very important point. So what is the characteristic point of malignant hyperthermia? Inhalational agents increase ER and decrease abolish response to hypercapnia, temperature, onset, rise in temperature. Yes, EtCO2 rise. That's a very good point. One of the most sensitive indicator for malignant hyperthermia is temperature. Right. So if it is a case of, this is a case of second stage of ether staging, right? So we all know EtCO2 is increased. Everyone is pointing out. So basics are very strong. I'm very happy to see all the responses. Temperature in malignant hyperthermia is the last one to be raised. So the most sensitive sign to be detected on malignant hyperthermia is the rising in the EtCO2 level. Very good. Everyone is on the same note. So I want to add one point here. What is the significance of this ethers staging? Masseter spasm. Yes, we have one more question there. We'll go to that. Rise in EtCO2 and Masseter spasm. We'll talk about it later. So yes, what is the significance of this ether staging? Goodell stagings of anesthesia. You might have known this. There are 4 stages: stage 1, stage 2, stage 3, stage 4. Stage 3 is again divided into plane 1, plane 2, plane 3, plane 4. What is the significance of it? Now, the significance is very simple. Whenever you are anesthetizing a patient, described with inhalational induction, yes, that's a ether induction. What is the significance? There is one important reflex. I'll tell you one incident. That's very, very important reflex. That is called Brewer-Lukehard reflex. Have you heard this name, Brewer-Lukehard reflex? I'll tell you this incident. You know, the stages of anesthesia. If you see any old-timer surgeons, whenever they are touching a patient before the start of the surgery, they will take the permission of the anesthetist. Have you noticed them? Now, not nowadays, these younger surgeons, they are not, when I am inducing the patient, many senior anesthetists, they will not allow the patient to be touched by the surgeon. And even surgeons also, yes, anal sphincter causes laryngospasm. Yes, what is the reason for it? Not vagal response exactly. What happens is whenever you are anesthetizing the patient will be going from plane 1 to plane 2 to plane 3, right? So if there is an inappropriate stimulus, that is perceived by your body as a noxious stimulus. Why ether staging has become so popular means you have to make sure. That's the reason why after giving thiopentone sodium, you will just see whether the eyelash reflex is lost or not. Right? So the same reason applies in good old days when they were using only ether. Then they used to observe the stages, and at one stage only you need to induce the patient or you need to allow the surgeon. That is called surgical plane of anesthesia. Stage 3, plane 3. That is called surgical plane of anesthesia, right? So when the patient is not in adequate planes of anesthesia and you try to manipulate the things, there might be severe noxious stimuli followed by vagal response, severe bradycardia, laryngospasm, bronchospasm, hypoxia, leading to cardiac arrest. There are so many times this has happened, and very commonly that is seen with anal sphincter dilatation. Many people think that anal sphincter dilatation is a very small procedure. Yes, it's a very small procedure. But if you want to get this anal sphincter dilatation in spontaneous ventilation, your reflexes should be at the stage 4. Stage 4 is the medullary stage of paralysis where anal and carinal reflexes are lost. So go back and see the stages of anesthesia beautifully. At each and every stages, there will be loss of reflexes will be there. And if you want to do anal sphincter under sedation or under monitored anesthesia care, make sure that the patient is in stage 4 where the patient is having medullary depression. So that much amount. The good point is anesthesia has become safer over a period of times, right? So what we are doing is right now we are doing saddle block of anesthesia, right? So this reflex name is important. That is called Brewer-Lukard reflex, right? So this is a very significant historically. So I just wanted to add this one. Right? So most of you are on same note. I'm very happy to see a lot of good responses are there. That's the reason why, I want to gain the confidence, or you should gain that momentum before going to the examination. If I create some crazy MCQ, what will happen? It might create some, that panickiness or FOMO before the examination. Right? Shall we see the next question? Yes, the next question on the screen. Yes, a 49-year-old patient is undergoing craniotomy for tumor resection. Intraoperatively, the patient received drugs including thiopentone, Rocuronium, isoflurane, and fentanyl. The patient is brought to post-anesthesia care unit with a heart rate of 58 per minute, blood pressure of 196 by 96, and oxygen saturation of 98. Few moments later, the patient has 2 episodes of vomiting. You would then, what would you like to do? Option A, give ondansetron. Option B, give metoclopramide. Option C, fentanyl. Option D, call neurosurgeon. Yes. Yes, raised ICP, raised ICP, raised ICP. Yes, very good. Everyone is on same note. Very happy to see so many people are marking the right answer. Yes, call the neurosurgeon. Why call the neurosurgeon? Because this is a classical case. After a neurosurgery, the ICP will be raised. So post-operatively, the rise in ICP, yes, Cushing triad, high rise in ICP. So everyone is on very good note. Bradycardia, hypertension, irregular respiration. Very good. So everyone knows the exact answer. Post-operative care management of a neurosurgical patient is very, very important. Make sure that the ICP is not elevated. Right. So how to know whether the ICP is elevated or not? The classical presentation in the post-operative period is patient will have nausea, vomiting. Right. So the vomiting itself will tell you that the patient might have raised ICP. Right? Nausea, vomiting. Yes. What do you mean by NV? I don't know. Okay, right. Yes. So most of the times what happens is very good point. What we see is patients generally, yes, pupils sometimes pupils will be dilated. Pupils is good sign, but not immediately. Right? So nausea, vomiting, yes, that's a very important sign after the patient is having this headache, nausea, vomiting. Very good. So very important post-operatively, the same guidelines what we follow intraoperatively to manage the ICP. is the same what we follow in the post-operative period for the neurosurgery patient. Putting the patient in a slight propped up position so that there is a good drainage of their right. And second thing is you have to make sure that the patient is not having hypoxia or hypercarbia. One important point is whenever there is any infection in the neurosurgical patients, make sure that the temperature is not rising because this increases the cerebral metabolic oxygen consumption. Okay, so that's very, very important. Same way. So one question I would like to add here, which of the following fluid is contraindicated in neurosurgical patients? So the same thing, I don't want to discuss the entire thing, is D5, 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 dextrose. Why? Why dextrose containing solutions? Yes, most of them hypotonic. Very good. Exactly. So any hypotonic solutions you should be avoiding. Yes, the reason being is once the dextrose gets metabolized, whatever the free water will be there, that will again rise the ICP, right? So that's the reason why not only for neurosurgeries, even for resuscitation also, we will avoid dextrose containing fluids. Most of the times we will prefer to use isotonic solutions. That's either ringer lactate or normal saline, right? Cerebral edema. That's everyone is on right note. So I'll move to the next question. This is a very basic question which I have started with, right? Shall we see the next question? Yes, a 4-year-old boy with autism undergoes surgery under general anesthesia. At the completion of the operation, the patient remains unresponsive but is breathing spontaneously and has a mild gag response to oral suctioning. The anesthesiologist extubates the patient, provides 100% oxygen by face mask. The anesthesiologist notes that the ventilator shows no EtCO2. The pulse oximeter reading then drops rapidly to 70% from 100%. What is the next best step in management? Okay, administer albuterol, insertion of nasal trumpet, endotracheal reintubation, administration of succinylcholine. Yes, what is this diagnosis? Very commonly, yes. Yes, very good. Extubation in lighter pain, very good. How do you identify laryngospasm? The diagnosis, everyone is on very happy to see. Everyone is saying laryngospasm, laryngospasm, laryngospasm. Wonderful. How do you identify laryngospasm? This is the classical presentation of laryngospasm. No chest rise will be there. Not only no chest rise, EtCO2 is zero. Yes, the silent chest, bag not moving. Not only EtCO2 zero. Yes, there is tracheal tug and paradoxical respirations. Sometimes you might see the paradoxical chest wall movements. A bag is tight, absent breath sounds. That is the reason why very important. Whenever after you extubate the patient, make sure you auscultate. Yes, paradoxical respiration. The chest wall will be moving in an opposite direction. So make sure that you auscultate before extubation. Once you extubate the patient, although you can clearly see it. So the classical presentation of laryngospasm is this rapid desaturation. Sometimes it might be associated with suprasternal restrictions. Sometimes it might be associated with stridulous sound. Sometimes it might be associated with stridulous sound, and there might be bradycardia if the patient is going into severe hypoxia. So initially there might be some tachycardia as a response to hypoxia, but as you go later, it might turn into bradycardia stage. So what is the drug of choice in management of laryngospasm? What is the drug of choice? Not scoline. Not scoline. Scoline is generally, yes, Larson's maneuver is the first step. Propofol, wonderful. Propofol. You might have given many times this drug, propofol, right? So propofol, it has maximum inhibition. Deeper the planes of anesthesia, wonderful, right? So propofol has got maximum inhibition of airway reflexes. So what will happen is, if you give propofol immediately, whatever the noxious stimuli, the reason for laryngospasm is some blood or suction fluid, something like that. It is trickling on your larynx. The patient is not in adequate planes. Oxygen flush propofol. Sometimes oxygen flush might not be very useful because nowhere in any standard literature it has been said to use oxygen flush. Okay, so best is to give propofol, hold the mask, do the Larson's maneuver. This is given in Miller's anesthesia textbook. If the spasm is so severe, yes, sir, difference between bronchospasm. Yes, that is my next question. What is the difference between bronchospasm and laryngospasm? How do you differentiate between bronchospasm and laryngospasm? Yes, V's, not every time you will hear the V's. V's is present means I'm very happy. Why? Because some air is entering. Some air is entering. Sometimes the V is labored breathing in bronchospasm, no chest rise. And chest rise will be there, yes, yes. ETCO2 waveform, very good. Capnography that shows sharp fin pattern if the patient is in. And second important thing is in any case of barring, why not tongue falling back? A nasal trumpet first. So if it is a tongue falling back, you see here that much amount of rapid desaturation will not be taking place. Can you understand here? So tongue falling back will not lead to that much amount of rapid desaturation within fraction of seconds. Right? Bronchospasm will have sudden unexplained tachycardia and never it is laryngospasm is never occur during the surgery. Laryngospasm classically seen after extubation or sometimes if you are trying to use gas induction. And when the patient is not in adequate planes, you try to insert the LMA, you will get laryngospasm. That is one of the commonest reason where you get laryngospasm during induction. Definitely 90% of the cases you will get it at the time of extubation. Whereas bronchospasm can occur during the surgery and after the surgery. And whenever it occurs during the surgery, it will have sudden unexplained tachycardia, hypertension, increased airway resistance, and a sharp fin pattern of ETCO2. What do you mean by sharp fin pattern? There is an increased upstroking of phase 3 of ETCO2. Right? So that is what classical presentation. And when you hear with stethoscope, you will hear the V's. So if it is bronchospasm, then what will happen? Yes, beta angle will be, yes, the first angle is alpha angle, the second one is beta angle. So there is an increased upstroking will be there. So that is a classical presentation of bronchospasm will be there. So tongue fall can be there, but that will not be that much. So if it is bronchospasm, then we go with albuterol, salbutamol, whatever that is there. Then most of the times URTA bronchospasm, if it is there for the patient after the extubation, you can hear. That is why I said you have to auscultate. If you are getting bronchospasm immediately, you will hear. And bronchospasm will never cause rapid desaturation. Whereas laryngospasm rapidly desaturates. So the first step in laryngospasm management is application of the pressure here and then propofol. If the spasm is very severe, scoline. Right. One important question I would like to ask you. Right. If you give scoline in a patient with laryngospasm and you have intubated the patient, answer is D. Yes, the correct answer is D, Dr. Ravi. Right? If you have given scoline for the patient and if you have intubated this patient, now tell me what will be the duration of action of succinylcholine in this patient? Will it be prolonged? If it is prolonged, how much time? Prolonged. Risk for choline apnea. Yes, prolonged. Why? Why? Everyone is saying prolonged. Why it is prolonged? Not 1 hour. Never it will be 1 hour. Never it will be 1 hour. 10 to 20 minutes. Why? Yes. 10 to 20 minutes, 20 minutes, right? Exactly. Perfect. Everyone with Dr. Vijay Raj, Dr. Sonali. Yes, before reversal. Why? I want to know the reason why. That's where, I want to strengthen. Prolong. Why? Prolonged due to reversal. Why? I also know this. It is due to, I have given neostigmine. So what? What reversal is neostigmine is doing to my scoline? Scoline binds on acetylcholine receptors. No, not like that. No, not phase 2 blockade. Phase 2 blockade is an entirely different entity. Neostig, yes, Dr. Pratik. Yes, right. And very clearly, Dr. Neostigmine inhibits plasma cholinesterases. That is one of the beautiful property of neostigmine. So if there is prolongation of duration due to acetylcholinesterase presence, yes, very good. So someone has said it very rightly. So neostigmine, what it will do is it will inhibit the pseudocholinesterase level. So that's the reason why the duration will be prolonged for around 10 to 20 minutes. Not only neostigmine, any drugs like pyridostigmine, OP poisoning, some anti-cancer drugs, ethambutol, right? And all these drugs, what will happen, there will be prolongation. So there is a decrease in the concentration of acetylcholinesterase, not acetylcholinesterase, pseudocholinesterase, because acetylcholinesterase is going to metabolize acetylcholine. Here we are talking about succinylcholine. Why it is called pseudocholinesterase? Because, acetylcholinesterase will inhibit only acetylcholine. Succinylcholine is two molecules of acetylcholine. Succinylcholine is two molecules of acetylcholine. It is binded by some sulfur atom. If I am not wrong, it is binded by some sulfur linkage. So in order to break this, it is called pseudocholinesterase, cholinesterases. Is it clear? So the reason for prolongation of duration after choline, one of the reason up to 10 to 20 minutes is due to inhibition, decrease in the concentration of the enzyme. Typically, decrease in the concentration of enzymes is seen with the administration of drugs like neostigmine, pyridostigmine, some anti-cancer drugs, bambuterol. Some drugs will be there, ectopiate, which is used as a eye drops. Okay, so all these drugs, they will cause. Not only this, there will be prolongation of duration of action in pregnancy. Why? Neostigmine prolongs the action of choline. Yes, you're right. Why? Neostigmine, it inhibits, right? So there will be duration, prolongation of duration in pregnancy also. Why? Pseudocholinesterase deficiency? No, not exactly. Again, there is decrease in levels of concentration of pseudocholinesterase in pregnancy. Acute liver failure. Yes, pregnancy decrease in the level. Can you understand? So someone has mentioned it very clearly. One of the physiological changes which is very important for our anesthesia perspective is because the blood volume increases in pregnancy, the pseudocholinesterase levels will be diluted. So increased in volume of distribution. Yeah, blood volume is more. So what will happen is there will be dilution. So there will be decrease. So any cases of acute liver failure, pregnancy, yes. Miller said it. It is not clinical. Yes, that's the reason why your liver and all the things they are. It's extended only up to 20 minutes. That's what I said you. So 10 to 20 minutes, not much. Generally, the duration is less than 10 minutes. But in cases of acute liver failure, pregnancy, neonates, old age, or usage of certain drugs, like neostigmine, pyridostigmine, the duration will be prolonged up to 10 to 20 minutes. That's not very much significantly change. Why? Because you have lot of reserves of pseudocholinesterase levels. Have you understood the reason? Right. So this is a classical case of laryngospasm. So very few cases are there, few clinical presentations are there, which you need to identify. Just tell me the diagnosis in your chart screen. So sudden unexplained, already we discussed two scenarios. One is bronchospasm. The second one is laryngospasm. The third scenario, which I wanted to tell you is sudden unexplained tachycardia. It's not there on the screen. Try to answer this question. Sudden unexplained tachycardia. Okay, let me finish off the scenario. The scenario is sudden unexplained tachycardia, hypotension, increased airway resistance. What is your diagnosis? Embolism, not malignant hyperthermia. Malignant hyperthermia will never have hypotension. Anaphylaxis. Very good. Anaphylaxis. Right. So anaphylaxis, again, one more clinical scenario. We have one more MCQ, I think, if I'm not wrong. So I have discussed about it. So sudden hypotension will be there, right? One more scenario, what is commonly asked in your entrance examinations is sudden unexplained tachycardia, hypertension, increased ETCO2. Already we discussed it. Malignant hyperthermia. Right, malignant hyperthermia. So these are our few case scenarios which might be presented in different conditions. Right, malignant hyperthermia. Is it clear? Thyroid surgery, tachycardia, hypertension, arrhythmias. What is your diagnosis? Thyroid storm. Very good. Thyroid storm. Very good. Right. Which arrhythmias you are expected in thyroid storm? Atrial arrhythmias or ventricular arrhythmias? Yes, atrial fibrillation. Wonderful. Atrial supraventricular tachyarrhythmias will be seen in an unprepared patient of thyroid surgery. So that's called thyroid stem, that is atrial fibrillation. Right. So these are few, there are only few classical scenarios in anesthesia. Just it's like a brush up. One more classical scenario in regional anesthesia where everyone would like to ask you high spinal and total spinal differentiation. Okay, so that's everything. I think you might be knowing it. That's not the context here. So we'll move to the next question and see the next question. Right. In the above scenario, if the patient's post-extubation condition is left untreated, the patient will most likely experience. Good. Everyone is marking negative pressure pulmonary edema. Wonderful. So that's everyone knows the reason for negative pressure pulmonary edema, because there is an upper airway obstruction. You are trying to forcefully. Yes, everyone is on right tone. Very happy to see. If, you try to take in forcefully, there will be increase. The pulmonary vessels will be dilated. There will be exudation. So it might lead to negative pressure pulmonary edema. So the first point, what treatment happen is the patient might collapse. The second thing is he might land up into negative pressure pulmonary edema. So the treatment for negative pressure pulmonary edema is again giving positive pressure ventilation. So typically, whenever there is obstruction, this is seen with negative pressure pulmonary edema. right? And one more, in neurosurgery case, I said you there might be causes of pulmonary edema again due to sympathetic stimulation, that too in the post-operative period. Right. So pulmonary edema, it can be divided into cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. Cardiogenic pulmonary edema, it's always due to the heart, where you can see the changes in the heart. That's the reason why you land up in it. Whereas negative pressure or sympathetic stimulation, all these things, yes, CPAP can be used if possible, or give positive pressure ventilation. That will be sufficient for the patient. Shall we move to the next question? Right. A 90-year-old male is presented to the operating room for surgical repair of right femoral neck fracture. His medical history is significant for chronic obstructive pulmonary disease and on home oxygen therapy. To assess the respiratory risk for this patient, which of the following will provide the least beneficial value? Option A, stat pulmonary function test. Option B, baseline chest radiograph. Option C, thorough history and physical examination. Option D, baseline arterial blood gas. Which of the following is least beneficial? Yes, I wanted to stress here because Miller 10th edition has got something different from compared to 9th edition. That's what I wanted. That's the reason why one of the reason. B, everyone is saying baseline chest radiograph. Okay. Yes. Okay. The answer will be stat pulmonary function test. Okay, the option will be option A will be the right option, right? Why? There, there is classical. There is one, the in Miller 10th edition, it has been written very clearly that assessment of cardiac function before a surgery and assessment of respiratory function before a surgery, right? What 10th edition has added, if you have time, just go through it. It has added European guidelines. Previously, in 9th edition, it used to add only two guidelines, American and Canadian system. I don't know what the reason being behind adding it. So 10th edition has added some European guidelines. I don't know if some examiner picks up this point, and if he tries to add this one, it might create some confusion among the students, right? So post-operative pulmonary complications, let us fix here. Post-operative pulmonary complications is seen in certain kinds of surgery, right? And what is the score, or what is the scoring system what we use? What is the scoring system what we use? Yes, very good. ARISCAT. Yes, ARISCAT scoring system. Very good. If the score is considered as low risk, if the values here less than, values are less than 26. Yes, someone is very close to the answer. 27, 26, right? Akshata, Dr. Harshchandra, 26, right? So now I would like to ask you, there are the factors what we divide the post-operative pulmonary complications are categorized into patient-related factors and procedure-related factors. So in patient-related factors, elderly age is one of the very risk factor, right? The second one is patient is a smoker, actively smoking patient. The patient is having all these, whatever that is there in the history, they will be categorized into this patient related factors. Now, yes, upper abdominal surgery, thoracic surgery, vascular surgery, all these categories will be added into the procedure related factors. Not only previous history, yes, very good. Now, I would like to ask you, is asthma a risk factor for post-operative pulmonary complications? Is asthma a risk factor for post-operative pulmonary risk factors? No. Yes. Everyone is on right note. Yes. A patient with stable asthma is not considered as a risk factor for post-operative pulmonary complications. Have you understood? Right? Who is risk factor? If a patient is having within a span of 30 to 60 days, if he has history of hospitalization with endotracheal intubation, very worsening asthma, then only he is categorized as post-operative pulmonary complication, acute episode, right? If a patient is having stable episode of asthma or he is a known case of asthmatic, then he is not be considered as a risk factor. So this scoring system, ARISCAT scoring system, there are so many scoring systems are there, but in Miller's anesthesia textbook, only ARISCAT, and most of the times we follow this ARISCAT scoring system only. And if the scores are less than 26, we consider it as low scoring system, right? So this scoring system is very, very important. It is there in preoperative evaluation chapter in Miller edition. Unfortunately, I can't write on the screen, so I'm not able to show all the scoring system, and I want to keep it very short also. I don't want to, it's very self-explanatory, very important. There are so many scoring systems like pneumonia versus respiratory failure scoring system, but these are all old age scoring system. What we are using is this scoring system that is called ARISCAT scoring system. Now, can you tell me one scoring system where would you like to assess if a child is having respiratory tract infection, whether he lands up in problem or not? How are you going to assess? What is that scoring system? Yes, wonderful, Dr. Anirudh. cold scoring system. Again, please go through these scoring systems because the recent edition has been really stressing on these scoring systems. That's the reason why I have ordered. So when do you like to order pulmonary function test in a patient? What textbook says? Leave about our practice, because we have different set of practice. So cold, yes, someone said, Dr. Yamini has also said very rightly, right? So when do you order stat pulmonary function test for the patient? Uncontrolled or recent problem? No. One, it's going to affect management of case. That's very good. Any one? Yes, lung resection. Any pulmonary surgery or lung resections, textbook says very important to measure the lung surgeries to check the pulmonary. Apart from it, there is no role of pulmonary function test. Postoperative pulmonary risk is also not considered as a yes, postoperative pulmonary risk. Though those who are having high risk thoracic cases, where only we will add stat pulmonary function test. Chest X-ray is considered as basic chest X-ray. It's very important because it will tell me that whether the patient is having, because he's already on oxygen therapy, and you might identify he's a known case of COPD. And can you tell us which new guidelines? Which one? ARISCAT guidelines. I said you pulmonary function test. COPD guidelines. Recently, also one guideline came that's not there in Miller's textbook actually. COPD 2024 guidelines are also came. Okay, right. So chest radiography. Yes, CAT. I didn't understand the CAT. Okay, right. So chest X-ray is ordered whenever you are having a patient with COPD, because we are suspecting sometimes there might be bullous lung disorder, or there might be bulle will be there, or if you are suspecting lower respiratory tract infection with purulent sputum, right? Then only, or fever is there. Whenever you are suspecting ventilator associated pneumonia, then only you have to order chest X-ray. But chest X-ray to rule out pre-existing bulle. Very good. That's what it's given in the Miller's textbook. What you are quoting is given in the Miller's textbook. So there are some specific indications when to take the chest X-ray. Never ignore this thorough history. That's obvious. That's a very big option which you cannot rule out. And baseline ABG. When do you like to order an ABG for the patient? ABG. OSA. Okay. Okay. OSA. Why? Why in OSA? Fat embolism, oxygen therapy. They're coming to only sepsis. Okay, we will stick to anesthesia only. COPD. COPD also, it's not, again, I wanted, yes, acute exacerbation. That's what it's given in the textbook. Whenever home oxygen therapy, why do you want to see? Someone has said OSA. Why do you want to see OSA ABG levels? Obviously, I'll tell you the answer before you type. So hypercarbia. Yes. Why you are interested in hypercarbia? Why? Yes, hypercarbia. Carbon dioxide, OSA, everyone knows the reason. Why? Trigger for the breath. Very good. So they are sensitive baseline carbon dioxide levels because they are sensitive. OSA patients are extremely sensitive to any sort of sedatives. So that's the reason why I want to know. And any acute exacerbations of asthma or any acute exacerbations of COPD, ABGs are the standard line of treatment. Okay, right? So intraoperative acid base balance, pH and PCO2 baseline PaCO2 value is patient. Yes, everyone is on right note. When you are suspecting severe suspect, that's again we are going out of the anesthesia context to the critical care. Yes, obviously, if you are suspecting some metabolic or respiratory acidosis, then obviously that's what. So before surgery, you might need to order an ABG only in case of obstructive sleep apnea, because to know the baseline CO2, and very importantly, it's any acute exacerbations. Then only you need to get this chest X-ray done. Right? So shall we move to the next question? Right. The next question, again, I just wanted to give this again cardiac guidelines summary. So just I'll read out the question. A 76-year-old female is posted for right THR. Her medical history is significant for coronary artery disease. Status post-stent replacement 6 months ago. A recent echocardiogram 30 days prior showed an ejection fraction of 30% along with evidence of inferior wall motion abnormality. Baseline heart rate is 60 to 65. She is on metoprolol and blood pressure is 125 by 60. In addition, the patient has severe COPD with home oxygen therapy and has obstructive sleep apnea on BiPAP. Which of the following perioperative management is not necessary for this patient? Option A, cardiac catheterization and need for CABG surgery before THR. Option B, communicate with the cardiologist to confirm the patient is medically optimized. Option C, conservative management initially and then post after 12 months. maintain hemodynamic stability during THR surgery. Yes, everyone is on. I made the options. I wanted to tell you. See, conservative management initially, no. Someone, Dr. Arun has said, C, no. Yes, what guidelines have said when to do a surgery? This is considered as THR is not considered as a emergency surgery or not elective surgery. It is a time sensitive surgery. Yes, for any bare metal stent, unless and otherwise they stated, it will take it as bare metal stent only. We'll take it as drug-eluting stent only. So unless and otherwise they state it as a bare metal stent, you have to assume, because most of the places we think that it is drug-eluting stent only, right? If it is drug-eluting stent, as per ACC AHA guidelines, you have to wait for 6 months. If it is bare metal stent, how many days? Yes, bare metal, 1 month. Previously, it was something different. In ninth and 8th editions of Miller, it is different. Yes, 1 month, 4 weeks, or 30 days, 28 to 30 days, it is mentioned clearly. Bare metal stent is 30 days, whereas drug-eluting stent is 6 months. If it is a time-sensitive surgery, you can plan between 3 to 6 months, like onco surgeries, ortho fractures, and all these, they become time-sensitive surgeries. You cannot wait till the disease gets progressive, right? As I said, Miller 10th edition has mentioned American Society drug-eluting stent. Yeah, that's what I said 6 months, and some said 1 year. No, ninth edition also it said 6 months only, because ACC AHA guidelines has mentioned that first came in 2000, if I'm not wrong, 2017. I just don't remember the number. 2017. Yes, exactly. 2017 ACC AHA guidelines, and still we are following the same guidelines. Okay, if you are using the previous guidelines, when I was doing, or when I am in practice, when I did my PG, it was no, drug-eluting is changed. That's what I wanted to highlight here. Drug-eluting, previously it was 12 months, but it changed to 6 months. That's what I wanted to highlight here. Drug-eluting stent, Miller 9 said 6 months. Someone said what Miller said. I started reading Miller's edition from 6th edition, so to 10th edition I started reading it. So what I noticed is, in the previous editions it was 12 months, but it has changed to 6 months. Time sensitive, 3 to 6 months. Okay, right. So what I wanted to signify in this question is not the answer. It's already everyone has said, right? Option A, cardiac catheterization. Now I wanted to quickly tell you what is this ACC AHA guidelines. Then comes Canadian Society of Guidelines, then comes European Society of Guidelines. So once I tell you, just go through that algorithm, because of so many reasons, copyright and all the things, I couldn't include on this PPT, but you can easily get these guidelines. So ACC AHA guidelines, it has got 6 steps. In step 1, up to step 3, all the guidelines says the same, more or less they say the same. In step 1, if it is an emergency surgery, go ahead and take it for surgery. In step 2, you have to postpone some of the elective surgeries. What are the cases you are going to postpone in step 2? In step 2, I'll only tell. Don't worry. Just try to listen it. Suppose if you are suspecting severe valvular heart disease, right, or recent unstable angina for the patient, or patient is having severe valvular heart disease, or significant arrhythmias are there. Yes, very good. Significant recent MI or unstable angina, valvular heart disease are there. Then you need to optimize the patient general condition up to 60 days. It has mentioned very clearly. You have to optimize. You need to know the condition in step 2. For any elective surgery, you need to identify acute coronary syndrome, recent MI or unstable angina, or significant arrhythmias, or any valvular heart disease. The patient needs to be optimized for around 60 days period will be there. So within this period, you need to optimize the patient and you need to take him for surgery. Right. In step 3, what we do in ACC AHA guidelines is we use this RCRI, Revised Cardiac Risk Index. So it has got a scoring system. Each point will have a score, one point we will assign to it. So if a patient is having past history of MI, we'll give 1 point. If a patient is posted for major surgery, then again, yes, 6 points are there. So please go through the 6 points basing on the number of points. In that 6 points, one thing is very important: past history of CVA, CKD, when to use Gupta scoring system. Gupta scoring system, I don't think it is given in any standard textbook, man. So, okay, so we'll go this ACC AHA guidelines only, right? So serum creatinine greater than 2, that is very, very important. So RCRI scoring system, it has got 6 points. The 6 points: diabetes mellitus requiring insulin, serum creatinine greater than 2, past history, insulin dependent, yes. Past history of CVA, past history of congestive heart failure, major surgery, past history of myocardial ischemia or infarction. So all these 6 points, it has got scoring system. is there a change with respect to insulin dependence? Yes, insulin dependent diabetes mellitus only is considered as a risk factor, and we will allot one score. Okay, so this is what we do. If the scoring system is the patient is having low score, that means you can take it for surgery, right? If the patient is having high scores, is having risk factors in ACC/AHA guidelines, in step 4, we will go for stress testing. Either it can be dopamine stress testing or it can be any kind of stress testing. In step 4, in step 4, we will assess the functional capacity of the patient. If the patient is belonging to score is more in the step 3, in step 4, we are going for the functional capacity of the patient. If the patient functional capacity, again, functional capacity is denoted by your METS, metabolic equivalent task, or Duke score is also there. Okay, so if the Duke score or Met repair score is also there. So if the Duke score, yes, DASI score, right, very good. Duke's assessment, self-assessment score is there, or Met repair score is there, or Met score is there. If the Mets are very low, less than 4 milliequivalents, till now everyone is telling the only one word because lot of numbers are coming into the picture. If the Mets are very low, then only go for stress testing in step 5. ACC/AHA guidelines has clearly mentioned up to step 3, it is RC/RI scoring. In step 4, we will assess the functional capacity of the patient, and we will go for stress testing only if the functional capacity is very low. Right? Then, if the functional capacity is very low, then we go for stress testing. If the stress testing is positive, then we will go for angiography or cardiac catheterization. Right? This is ACC/AHA guidelines. Canadian Society of Guidelines also mentioned almost like same thing only, but instead of all these things, what they will do is they will measure BNP and pro-BNP values. They really concentrated on BNP and pro-BNP values. So they have categorized the patients and they are asking to monitor the BNP and pro-BNP values. If it is less than 200, 250, that's considered as normal. More than that, it signifies that the patient is having cardiac problem. Whereas European Society guidelines, what they have mentioned is they have combined all these people, European people, they combined Americans and Canadians, and what they have done is yes, top levels as well as BNP, pro BNP, and they have combined this RCRI scoring system. And they have used this low risk surgery, intermediate risk surgery, and high risk surgery. So for any low risk procedure in any of the guidelines, it has mentioned that no need of further investigation. For intermediate and high risk patients, if the patient is having highest scores or if the patient is having low metabolic scores or functional capacity is very low, then only we go for more invasive tests or like cardiac angiography and all these things. Then only we will get a cross consultation. European guidelines have mentioned to go for cross consultation for high risk surgeries. Whereas in American and Canadian Society of Guidelines, they have not mentioned anything. So it's worth of looking at all these 3 guidelines before going for the examination. So I just superficially briefed you that algorithm. If you look at that algorithm, it is beautifully self-explanatory. So the highlight point is Canadian Society. Yes, please mention European article. It's there in the Miller textbook. Which one to follow? Mostly we follow, our examiners will follow ACC/AHA guidelines only. But why I am stressing it? Because I don't know, Miller's textbook is from America. Most of the times they used to give previously up to 9th edition, they used to give only American and Canadian guidelines. I thought they are like that only, but recently they have added this European guidelines. So in European guidelines, they mention this proponents, pro BNP and all these things, low risk, high risk, intermediate surgery. So that's more stratified formation in European Society guidelines, which I have noticed. So it's there in Miller 10th edition. Just go through it, and no guideline has mentioned for low risk surgery do any special testing. You can go as it is. Right? For intermediate surgery, if the patient is having some problems, then you need to evaluate. If it is high risk surgery, then you need to get properly evaluated. Right? So this is what they have clearly mentioned it. Please go through these algorithms. Due to copyright infringement and all the things, I have not kept it here because of short span, and I just wanted to tell where to look at these guidelines also. Right? So the final answer is option A. Option A, don't go for cardiac catheterization and need for CABG prior THR because already she has underwent stenting. Right? Cardiac patient, when to order echocardiogram, ECG? Again, this is a very beautiful question. Yes, ECG and echocardiogram are not ordered as a routine investigation. Echocardiogram should be ordered only if the patient is not evaluated since 1 year. That's what it has been mentioned. If your patient is having past history of MI and it has got not evaluated since 1 year, or if the patient functional capacity is unknown, or if he is having shortness of breath due to any reason, it can be cardiac shortness of breath due to unknown reason, then only you have to get echocardiogram. Whereas ECG also more or less same, age greater than 65 years, patients with history of arrhythmias or palpitations, history of arrhythmias and palpitation, and again myocardial ischemia or infarction not evaluated since 1 year, then you need to go for ECG guidelines. Okay, again, no need of repeating this echocardiogram. Should we follow 2025? 2025 AHA guidelines are not yet released. Not yet released. Yes, recently one guideline has been released, that is for not anesthesia related, but recently, 2 days, 3 days back only it has been released. That's for unstable angina, chest pain management, not for anesthesia related. Maybe 2025 AHA guidelines, it will come in September, October, if you are not wrong, because one of my senior colleague works for this ACC AHA. So he used to tell like September, October, November, somewhere between. So by that time, your exam will be over, if I am not wrong. So don't worry about it. So till today, we are still following the same, these guidelines only. 2022 is the European guidelines. AHA guidelines are going to change. One, angina management, they have received, released recently. ASRA guidelines, I have not seen recent ASRA guidelines, but not much change in the last ASRA guidelines also. Regional anesthesia guidelines. Okay, not big change is there in the regional anesthesia. Same low molecular weight heparin 12 hours, warfarin 5 to 7 days. Okay, if it is regular heparin, it is 6 hours. If it is high dose of low molecular weight heparin, that is therapeutic dose, it is 24 hours. Aspirin, very clearly it has mentioned 3 days. Only if it is major surgery. Clopidogrel, 5 to 7 days. Clopidogrel, ticagrelor, all these drugs. Ticlopidin, 10 days. Okay, so there is nice, beautiful column is there regarding the guidelines. I don't think, because examiners, unless I don't think in NEET SS, they will ask the moment it is released, because by this time, if it is on 2 weeks, by this time it's logically right to go with the guidelines that is there in the textbook. Okay, so whatever the textbook says, because I know few of my professors used to set the question paper, and we need to give the reference. You cannot say this is the right answer. CPR guidelines also 2020 only. CPR guidelines also 2020 only, not yet released. They are going to be released in October, November, something like that. Okay, so they have to give the textbook reference. So they will pick up the Miller's anesthesia textbook as reference only. They will not give any reference or articles that might not be suitable. We don't know exactly for SS, but it used to be happen with Marrow PG and all these things. Okay, shall we move to the next question? So please stress on these guidelines. And one more important point, I used to think one thing, that is how many days these blood tests are valid. I wanted to ask this again. Textbook, leave about your institutional practice. How many days, whatever the blood orders? No, 6 months, no, 3 months. No, 3 months. I also used to think 3 months only, but that's the reason. Not 6 months. 1 year, no. 2 weeks, no. Too early. The answer is 2 months. 2 months. If the patient condition is stable, that depends on COMAC. That's what I am telling you. If the patient condition has not changed much, the previous blood reports up to 2 months is accepted. What we follow in our institute, I also follow 3 months only. But yes, depending on the comorbid conditions. But 2 months is considered as standard. Okay, that's as per textbook. Again, I am here to tell you, does it make any difference? We are not going to debate on this, right? 2 months is given in the textbook. Okay, depending on the comorbid conditions, if the patient is generally stable and whatever the reports that are there, that is 2 months that we can be accepted. Okay, shall we move to the next question? Right, the next question, a 23-year-old male patient with no medical history significant posted for laparoscopic appendicectomy on induction of general anesthesia with propofol and administration of succinylcholine. The patient developed severe Masseter spasm. Which of the following should be done in this situation? Cut down all inhalational anesthetics and give 100% oxygen, insert LMA and continue oxygen and propofol, reschedule the case and send for evaluation, increase the dose of succinylcholine. It's not a case of malignant hyperthermia. Those who are thinking this is a case of malignant hyperthermia, this is not the case of malignant hyperthermia. Increase the dose of succinylcholine. Yes, increase the dose of succinylcholine. It's a lot of controversy between A and B. The answer is B. Cut down the inhalational anesthetics and give 100% oxygen. Yes, cut down inhalational. This is not a case of malignant hyperthermia. Please differentiate between malignant hyperthermia and Masseter spasm. Masseter spasm is a spectrum of disease that is associated even in normal persons also. Right? Masseter spasm is characterized by tightening of masseters and lateral pterygoid muscles after administration of succinylcholine. So it is a spectrum where it will be starting with tightness, followed by very tight, followed by locked jaws. And only in the cases of locked jaws where you will see rising in the body temperature, rising in the EtCO2 levels, and with pigmenturia, then only we consider it as malignant hyperthermia. 80% of the cases of masseter spasm will not land up into malignant hyperthermia. Masseter spasm itself, it tells you there is some caution should be there. It tells you there should be some caution should be there. Can you understand the logic? Right? Masseter spasm means you need to evaluate, you need to continue. Because what we were thinking about malignant hyperthermia, I don't know. Most of the students I have asked, they think that malignant hyperthermia can present most of the times. Classically, it will present during the starting of the surgery, but it can present during the surgery also. It might not be an immediate response. So, sudden unexplained tachycardia with rising EtCO2, and that too with a step ladder pattern of EtCO2. That's classical of malignant hyperthermia, right? So, if you are seeing this with hypertension and increasing body temperature, then it is a case of malignant hyperthermia. So, if it is alone masseter spasm, you need to be very careful. That's what the textbook says. Previous edition, it has mentioned that to give the increased dose of succinylcholine, unless and otherwise, there is no rise in body temperature. Right? But recent 10th edition of Miller's anesthesia textbook, nowhere it has mentioned to give or increase the dose, because we are thinking that we have given. Nowhere it has mentioned that I have used the dose. So assume that on induction with general anesthesia with propofol and succinylcholine, assume that I am using proper dose of succinylcholine only. So you have to cut down, provided if it is going into it, you need to monitor this patient. Right? You need to monitor this patient, and if the patient is going to be cut down all inhalational agents and give 100% oxygen is the safest option out of all the given options. Nowhere it has mentioned that give or increase the dose of succinylcholine, because if it is going into severe thing, we might lose the patient on the table. Right? So 20% of the cases alone masseter spasm, no other muscles will be rigid in case of masseter spasm. After giving succinylcholine, if unable to intubate, next dose of succinylcholine, if required, what should be the dose? Next dose will be the same. You have to give 1 to 2 mg per kg. If you are still not giving, if patient is not getting from 1 to 2 mg per kg, you have to continue mechanical ventilation, or you can give Rocuronium, NDMR. Yes, Dr. Deepak has said you have to use muscle relaxant like Rocuronium, cut down all inhalational anesthetics. Nowhere it has mentioned. Previously, it has mentioned increase the dose. Most of the times it is due to inadequate dose, but yes, it's not wise to give the increased dose because it is not proven clinically. But yes, the masseter spasm might reflect the severity of malignant hyperthermia. It's very rare. Only masseter muscles will go into spasm. All the limb muscles will be flaccid. This is the classical presentation of masseter spasm. Can you understand it? Only this masseter muscles will go into spasm. Limb muscles will be flaccid. And if it is simple masseter spasm, you can deepen the plane of anesthesia and you can intubate the patient. Right? If it is going into locked jaws, then we are dealing with a case of malignant hyperthermia. Right? So this is about malignant hyperthermia, masseter spasm. And recently, not recently I say, but have you ever seen this, what we call this dantrolene sodium? Right? So how do you reconstitute this dantrolene sodium? Recently, not recently, 2013, we have got this lyophilized form, 60 ml NS, water, not NS. Normal saline you should not use. That's what I wanted to ask here. So you should not use normal saline to dilute with dantrolene sodium. Dantrolene sodium has got, yes, dextrose you can use, D5 you can use, but sterile water or distilled water is a good option. Sterile water or distilled water. Mannitol, it contains mannitol. The recent preparations, it has got mannitol. Yes, it is lyophilized form. So previously it used to be available in 20 mg vials. So we used to use around 20 vials. What is the dose of dantrolene sodium? You should be knowing all these things. 2.5, 1.5, 2.5. Okay, 4 to 6 mg, 2.5 mg. Yes, 2.5 mg per kg. Yes. 2.5 mg per kg, right? So 2 to 4 mg per kg. Yes, very good. Yes, most of you are right. So you have to reconstitute with distilled water or stellar water because the pH is 9.5. Dantrolene sodium is a hydantoin derivative and it will directly inhibit the calcium release. Either you can use dextrose solutions, but never with normal saline because normal saline is not normal. You all know the reason. Normal saline is slightly acidic. It might precipitate. So you have to use distilled water or dextrose containing solutions. Right? Shall we move to the next question? Right. The next question. A 23-year-old man arrives to emergency room after having an assault at his home. On examination, the attending doctor notices a stab wound on the abdomen with 3 centimeters entry wound in the epigastric area. He is listless with respiratory rate of 30 breaths per minute, heart rate of 130, blood pressure 130 beats per minute, and a blood BP of 65/40. He has a firm abdomen with guarding. Identify the wrong step in management. Option A, chest X-ray is helpful in this patient. Option B, complete head to toe exposure should be a part of primary survey. Option C, if a fast scan is normal, laparotomy should be deferred. Option D, secure an IV large bowel is preferred over central line. So obviously option D is not a right option. Everyone might have dealt this kind of cases. What is the correct? Identify the wrong step. Yes, Yamini, C, 1 plus C. Complete head to toe exposure should be wrong step. Option A, chest X-ray would be helpful. Yes. So some people have said chest X-ray. Dr. Deepak has said chest X-ray is helpful. See here, they are saying that 3 centimeter entry wound in the epigastric region. So you have to suspect pneumothorax. You have to suspect pneumothorax, right? So chest X-ray would be obviously useful for these cases. You cannot say chest X-ray is not useful for this patient, right? Complete head to toe exposure should be part of primary survey. Any trauma survey, complete head to toe, A, B, C, D, E is mandatory. Any trauma, airway, breathing. Yes, ultrasound is obviously out of options. Ultrasound is better option because of late we are having ultrasound. You can easily identify any tension pneumothorax or whatever that is happening with this trauma, right? That's wonderful option. But in this option, chest X-ray would be very better option. You cannot deny the fact that you need to have a chest X-ray, right? So yes, next one, A, B, C, D primary survey includes airway, breathing, circulation, disability, exposure, avoid hypothermia. All these things are very important in primary survey of the trauma, right? If many people have mentioned C, yes, if a fast scan is normal, laparotomy should be deferred. This is a wrong statement. Why? Fast scan is useful. I don't know how many of you have done fast scanning, but of late we are doing this focus and fast scanning, all these things we are doing, and many people, many postgraduates are exposed to this scanning and all these things. So it's, and most of the institutes, they do this. It's not like they don't do it. So fast scanning is useful only to detect if there is any solid organ damage is there or not. It is never used to identify hollow viscous perforation, right? So fast scan is a useless thing to identify that you are, if you know, it is saying stab injury, so I am expecting hollow viscous perforation. Why I am expecting hollow viscous perforation? See the history. The patient is having blood pressure of 65/40, guarding abdomen, and all these things are there. So I am expecting hemoperitoneum causing shock. Yes, that can be there. That provided if you are stabbing the liver or spleen, hemoperitoneum, right? So if there is liver stab or spleen stab, whatever it might be there, any solid organ damage you can easily pick up by fast scanning. But whereas hollow viscous perforation, you cannot pick up with fast scanning. So doing a fast scanning and thinking that the patient is normal, like fast scan is normal, patient would be normal. No, it might not be a right answer logically. So fast scan, C option is the wrong step. So if you are seeing a patient who is unstable, then definitely go and open it up. No surgeon would like to wait. So unstable patient himself is an indication for getting operated. So there is no point of fast scan in this scenario, right? So option A, yes, you have to do it. Option B, you have to do it. Option D, obviously everyone knows this answer, right? So this is the question which I wanted to tell you, right? Shall we move to the next question? So happy to see all are on the same note. So let's see the next question. A 47-year-old male patient with a known history of hypertrophic obstructive cardiomyopathy is anesthetized with propofol and intubated. After induction, his blood pressure rises to 180/120 and heart rate rises to 110. 1 millimeter ST depression is noted. Which of the following interventions is most appropriate at this time? Yes. Avoid tachycardia. Yes, obvious, straightforward question. Yes. Hypertrophic obstructive cardiomyopathy is a dynamic outlet obstruction, LVOT obstruction. Tachycardia will cause LVOT. Dynamic obstruction will be there. So, how do you suspect HOCM? How do you suspect HOCM? Yes, everyone is on right note. Everyone is saying give esmolol, don't give nitroglycerin, nitroprusside, deepen the volatile anesthetic with desflurane. Why not desflurane? Sam on echo. No, yes, very good. Sam on echo is a wonderful finding. I want history wise. History wise, how do you suspect hypertrophic obstructive cardiomyopathy? Yes, someone said rightly. Syncope, sudden collapse. History will have a sudden collapse of hypertrophic. Any relatives or any of the close relatives, or he himself might have, sudden cardiac arrest. You might have seen these kind of cases are of late very commonly happening in our country of late. Those I don't know. That's the reason why I kept it here. So any history suggestive of sudden cardiac arrest in young male patients, think of hypertrophic obstructive cardiomyopathy, athletes dancing and all these things that are happening. Why not desflurane? Someone has answered it rightly. Yes, desflurane is a sympathetic stimulant. Out of all inhalational anesthetic, desflurane is initially, it's an irritant. So it will cause initial tachycardia. So deepening the plane of volatile anesthetic is a good option, but not with desflurane. Can you understand it? Because desflurane is an irritant, it will cause initial tachycardia. The initial tachycardia might again precipitate the outlet obstruction. So that's the reason why I kept this option. Right? Yes, halothane is a wonderful option. Isoflurane is a best option. Sevoflurane is a best option. Desflurane will cause initial tachycardia, but not after that. Everything will be same because of irritant nature. Right? Shall we move to the next question? Yes. The next question, 100 mg succinylcholine is administered to a 70 kg anesthetized man before intubation. The patient remains paralyzed for 45 minutes. Which of the parameters is not consistent with this finding? Option A, Debouquet number 50. Option B, homozygous for atypical cholinesterase. Option C, incidence is 1 in 480. Option D, presence of fasciculations with this dose. Come on. We were discussing about succinylcholine. What is the correct answer? Which of the following is not consistent? Fasciculations is present or not? Most of the times, succinylcholine will cause fasciculations. Incidence is 1 in 480. Debouquet number will be 20, 45 minutes. Okay, there is a lot of confusion. B, C, yes, C. We don't know. These numbers. Incidence is 1 in 3,200. Which one? Incidence, Dr. Kirtika. Incidence is 1 in 3,200. Which one? Homozygous. Yes. Is it homozygous or heterozygous? Yes, I wanted to highlight here what textbook has given. Yes, some of you are right. Yes, Debouquet number is heterozygous is 1 in 480. Yes, heterozygous is 1 in 480. So what is the correct answer? It is B. Homozygous atypical. Now see here. So there are reasons for prolongation of duration of succinylcholine. One is decrease in concentration. In the previous MCQ, we have discussed whenever a patient is having acute liver failure or whenever a patient is pregnancy, whenever a patient is on certain drugs. There are second conditions where the patient is having atypical pseudocholinesterase. Atypical pseudocholinesterase can be identified only by Debouquet number. Right? So Debouquet number is a qualitative analysis. So what we do is Debouquet is a local anesthetic which will bind to normal pseudocholinesterase. So what will happen in normal pseudocholinesterase means if you take the blood sample and add Debouquet, your numbers will be 80:20. That is normal. Right? Normal means you will come out of the effect of succinylcholine within 10 minutes. But if you are heterozygous, because why this is atypical pseudocholinesterase means on the 206th carbon atom, if I am not wrong, on the 206th carbon atom, guanine is replaced by adenosine. That's the reason why it will become atypical. Right? So what will happen is if you are having atypical pseudocholinesterase, one gene might be coding or two genes might be coding. If it is one gene it is coding, then it will become heterozygous atypical. If it is heterozygous atypical and if you do the Debouquet testing, the reports will be 50:50. And the duration, yes, 50 to 60. Yes, you are right, Dr. Shivani. So the duration will be around 45 minutes. The duration will be around 45 minutes to 1 hour. Right? So if it is homozygous atypical, then the Debouquet number will be 20:80. Right? It is the duration will be prolonged up to 6 to 8 hours in case of homozygous atypical. The incidence of homozygous atypical as per literature is 1 in 3,200. Whereas heterozygous atypical, the incidence is 1 in 480. 1 in 480. That's the reason why if a patient delays also 30 to 40 minutes, you need to wait if you want to do this debucane testing also. So I don't know in our country, I don't know any place where it is doing this debucane number, but yes, it's worth of remembering because most of the examiners will be asking you this question. So if it is homozygous atypical, your management will be, you can consider giving fresh frozen plasma. Yes, in Chennai. Yes, you can. Yes, there are some community things what we follow in our yes, how much ffp. Yes, it's not how much ffp because we don't know how much ffp there is. Nowhere it has been mentioned. We will transfuse generally around 1 to 2 units of fresh frozen plasma. 1 to 2 units of fresh frozen plasma. Most of the times it will try to recover the situation. But what textbook says is first continue mechanical ventilation, then consider ffp transfusion in these patients. Okay, that might be using. How much it increase the value, we don't know, because what we are, this pseudocholinesterase levels or cholinesterase levels, so is a very large volume. We are not trying to analyze. That's the reason why I said you debucane number is not a quantitative value, it's a qualitative index. It will analyze the enzyme activity, right? So you might have lot of, if you take out, it will be somewhere very large number is there. I don't remember exactly what is the exact value of pseudocholinesterase, but it's a very large numbers will be there, right? So how much it will increase, we don't know the exact reasoning, but generally we use around 1 to 2 units of ffp, and we will see most of the times it will recover the situation, right? And then comes one more situation that is called phase 2 block. What do you mean by phase 2 block? Phase 2 block. Someone has previously in one question, they have mentioned it as phase 2 block. Conditions increase in pseudocholinesterase levels. No condition will increase pseudocholinesterase levels. Even if it increase, there is nothing like increase in pseudocholinesterase levels. Yes, 5 mg per kg of succinylcholine. Accidental administration, not NDMR, DMR only. Accidental administration of large doses of succinylcholine will lead to phase 2 block, where receptor itself, yes, you are right, Dr. Kritika, right? Where receptor itself, 5 mg per kg, large doses means where the receptor itself is damaged now, right? Now the duration can be prolonged to, undefinite period. So this phase 2 block will resemble like NDMR block. What do you mean by will resemble like? 4 to 5 mg per kg. So succinylcholine acts like NDMR block. Yes, can cause, yes, damage to the receptor will happen. The voltage gated calcium channels and everything will be damaged. Do we give neostigmine? That is my next question. Do we give neostigmine in phase 2? Lot of confusion is there. Can we give or not give? No. FAFE. FE, I don't know what do you mean by FE. Yes, 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 no. Yes, on train of 4, fade is seen. Yes, because typically fade we consider as a presynaptic agent. Scoline acts as competitive block in high doses, phase 2. Very good. Yes, very good. The answer is you should not attempt giving neostigmine. That's what is given in the textbook. People say recommend it to give neostigmine, but textbook says don't give, because we are following the textbook. Neostigmine should not be attempted. That's what they have given, because sometimes there might be, a very varied response for it. So that's the reason why we don't give phase 2, right? What do you mean by channel block? So we will ventilate, continue to ventilate. And good point about this phase 2 blockade is, the receptors are the most dynamic things in your body that can happen. If the receptor is desensitized, there is something called as desensitization block, and there is something called as channel block. Okay, right? If the receptor phase 2 block is considered as one of the types of desensitization block, right? So where we are damaging the receptor, if it is damaged 30 to 45 minutes, sometimes more than that or less than that, we don't know exactly, your receptors will be newly generated. Acetylcholine receptor will be newly generated in your body, right? So what do you mean by channel block? Where can you encounter these channel blocks? Desensitization block means any damage. So when you use lithium and magnesium, classically, there are so many reasons are there. Even local anesthetics like procaine can prolong the duration of action, right? When you use lithium and magnesium, what will happen? to the effect of succinylcholine or NDMR. There will be prolongation because any heavy metals, yes, any heavy metals, they block at the channel level. They block at the voltage gated sodium channel levels. So there will be prolonged duration of action. There will be prolonged duration of action. So you need to differentiate what is the reason, whether it is absence is a very rare condition, whether it is atypical pseudocholinesterase or whether it is phase 2 block, whether it is channel block or desensitization. One of the reason is desensitization. So generally, if it is increase in duration, nowhere it has been mentioned that how much duration it will be increased. Right. So as we are talking about lithium and magnesium, one question I would like to ask you here, not related to this question, but just answer this question. If a patient is on lithium therapy and we are planning for a decade surgery, would you like to continue lithium or would you like to stop lithium? If a patient is on no, no means continue or stop, continue. Check the lithium levels. No, never. We are not going to check the lithium levels. Continue, stop. Yeah. So again, what is given in the continue? Yes, what is given in the textbook, I wanted to highlight here. Some people are staying stop. I clearly mentioned this as daycare surgery. Lithium is there, daycare surgery is there. Daycare surgery means I am using short acting drugs. And with the advert of drugs, this is the same line that is given in Miller's textbook. With the availability of atracurium, with the availability of mivacurium, you need not worry about the stoppage of lithium or magnesium. Generally, we don't stop magnesium because magnesium, if you stop, what will happen to you? You only can understand. If a patient is a PAH patient and the obstetrician has written magnesium sulfate, you will land up in big soup. No one can get you out of the soup. But lithium, most of the times, what will happen if it is a daycare surgery, and most of the places, if we are using atracurium and mivacurium, then definitely you can continue lithium. You need not check the lithium also because we all know atracurium, it will get out in your body through what we call this Hoffman's degradation. Mivacurium, it's not available in our country, but yes, mivacurium is also metabolized by pseudocholinesterase. Which antipsychotic drugs should be stopped in elective surgeries? Yes, antipsychotic drugs like MAO inhibitors, that too older MAO inhibitors. Yes, MAO inhibitors. Why? Older MAO inhibitors like seligelin. I think we have one question there. MAO inhibitors. Why? Why? Yes, serotonin G syndrome, something like cheese reaction that will happen. That too with interaction with synthetic opioids. Synthetic opioids include synthetic opioids. Yes, MAO inhibitors is not indicated due to more levels of category. 3 days, not 3 days, 3 weeks. 3 weeks. Yes, with not fentanyl and morphine. Fentanyl, yes, that's what I am saying you. Synthetic opioids like tramadol, meperidine, pethidine. Pethidine and meperidine mean same. Okay. MAO B, do not stop, book said. Yes. MAO A to be stopped. That too older MAO A. Older MAO A. Tapentadol. Yes. We have, I think I made one question basing on this only. No, tapentadol. Yes. Yes. So synthetic opioids like meperidine, pethidine, and tramadol. Generally, we stop MAO inhibitors. That too 3 weeks. Older MAO inhibitors because they cause this kind of reaction. Okay, so lithium and magnesium, if it is short acting drugs, you can continue if it's not a big problem. But if at all you're using long acting drugs, you need to stop 24 to 48 hours because there can be chances of prolonged duration. Can you tell me one drug which will decrease the duration of action of NDMR blockade? One drug which is commonly used. Calcium. Again, textbook says a different version. That's what I want. I also give calcium if a patient is not recovering from muscle relaxant. Magnesium sulfate, yes. Calcium, we check the levels. Actually, we assume that calcium, yes. Phenytoin sodium. Dr. Sonali has mentioned it clearly. Phenytoin sodium. This will decrease the duration of action. You might have experienced in any neurosurgery cases, the patient will come out of the effect of muscle relaxants quickly. Why? Why phenytoin sodium is making you to come out of the quickly? Phenytoin inducer, yes, inducer, very good. Phenytoin sodium is enzyme induction, hepatic microsomal enzyme inducers. So cytochrome P450 enzyme inducers. So there will be quicken the metabolism of this drug. So the patient will come out. There are only few indications where the drug action will be quickened. right? Most of the times, like local anesthetics, these calcium channel blockers, magnesium, lithium, all these things, they will prolong the duration of NDMR blockade. So this is about this blockade. Shall we see the next question? Right, quickly we'll see the next question. What is Cyanera escape? Option A, mixture of lignocaine and adrenaline, mixture of lignocaine and tetracaine. Option C, lignocaine, tetracaine and dibucaine, mixture of prilocaine and lignocaine. So obviously everyone will rule out option D. And this, I think, if I'm not wrong, because I attempted this question in NEET PGSS 2017, and I saw this question. 2017. Okay, I didn't join, but I attempted 2017. First time it has introduced NEET SS. Not lignocaine and adrenaline. This is there in Miller's textbook. A Cyanera is a mixture of, this is newer local anesthetic, the newer form of local anesthetics. Yes, Dr. Ravi has said clearly, lignocaine and tetracaine. Dr. Apurva also given the right answer. Lignocaine and tetracaine, it is coming. It's not available in our country, but it is there in the textbook. It is available with a heating element. So to produce surface anesthesia, we use this lignocaine and tetracaine with a heating element, and that is called as Nara or escaine. Okay, right? Then there is an older version which again coming into the picture, that is called TAC. It is tetracaine, adrenaline, and cocaine combination. Again, it's not available in our country. This is all the newer formulations of local anesthetics. In the textbook, it has given the liposomal bupivacaine, which will prolong the duration because it will prevent the degradation of bupivacaine and it will prolong the duration of anesthesia. The second thing is lignocaine and prilocaine. It is Embla cream, which everyone knows it will produce surface anesthesia. And lignocaine plus tetracaine, it is escaine or Cyanera, which comes with a heating element. And there it has given TAC, tetracaine, adrenaline, and cocaine mixture. That is also given in the newer formulations of the local anesthetics. Right? Apart from the tumescent technique, apart from the routine, whatever the mention they have mentioned. So one thing they have mentioned is the lignocaine plus tetracaine. And I attempted this question that's the reason why I mentioned. Rest of the questions I don't remember exactly. So this is what there are some newer formulations of local anesthetics, not only maximum dose of bupivacaine 2 to 3 mg per kg, because nowhere it has mentioned. It has given according to 70 kg person and depends on where you are injecting. Whether it is a minor nerve block or major nerve block. Minor nerve block means one. Bupivacaine with adrenaline or without adrenaline. Bupivacaine, we don't mix adrenaline. Why? We don't mix adrenaline. But whereas lignocaine, we mix with adrenaline. Why? Lignocaine, we mix with adrenaline. We don't mix, no, not precipitate, not cardiotoxic. Bupivacaine, if it enters into systemic circulation, then only it will become cardiotoxic. Acidic pH, again, I'll come back to this basic concept again. Yes, why don't we mix already? Yes, very good. Already it is long acting. Bupivacaine has got, the very high tendency to block the sodium channels. Very high tendency. You need not add. If you add also, there is no point in prolonging the duration. We are adding because lignocaine is an intermediate acting local anesthetic. Though to prolong the duration of anesthesia, we will add adrenaline. And by adding adrenaline, we are reducing the systemic absorption. We are increasing the toxic dose up to 7 mg per kg. Whereas bupivacaine, inactive sodium channels, there is no point in acting. Yes. Which sodium channels? Not only bupivacaine, even lignocaine and all these things, they are attracted towards open inactive sodium channels. Lignocaine has got intrinsic vasodilator activity. So it requires all local anesthetics. They got slightly amount of, which is the one local anesthetic, Dr. Abhijit, I want to ask you, which is the one local anesthetic which has got slight vasoconstrictor property apart from cocaine? Apart from cocaine, I am telling the same thing. Apart from cocaine. And not prilocaine, not, yes, Dr. Parthasarji has mentioned, ropivacaine. Out of all the local anesthetic, ropivacaine, other mechanisms of no block, they are not clinically significant. What textbook has mentioned in your pharmacology textbook, what is that big textbook, what we follow in pharmacology, Lippincott pharmacology, there they have mentioned that it will block potassium, calcium channel blockade, but lignocaine, local anesthetics, all local anesthetics, 95 to 98%, what we see the clinical result is due to blockade of sodium channel blockade only. Ropivacaine is the only local anesthetic which has got slight vasoconstrictor activity apart from cocaine. So previously cocaine was used because you might not have have seen it, or I have used it once when I was doing post graduation in 2007. We used to dip these balls, not very common. My professor was very fancy behind it. So cocaine, he used to dip the cotton balls and he used to put 10% cocaine solutions in the nostrils. And it's an excellent analgesia, at the same time, excellent vasoconstrictor. So it's, yes, 2007, he used to do it, all these kind of ether demonstration when on October 16th on ether day. But yes, I have seen only once. I have not used this cocaine. It has gone long back. Right. So, yes, one more newer formulations which I want to add. If you have not gone through it, please go through it. That is the newer formulations of etomidate is also available. Propofol, everyone knows the newer formulation, but etomidate newer formulations are also available. It's a very lengthy name. I don't remember the exact name. I will be honest with you. Right. So please go through the newer formulation, because of late many people are concentrating on the researching on the etomidate because of very good properties of the etomidate. Okay, it's a minimally respiratory depressant, most cardiostable drug. So, because of only inhibition of yes, carboetomidate, etomidate, there is a one big chemical name is there. Please go through it. Yes, MEC. That's what. Yes, exactly. Dr. Ravi has said clearly, right? Now, someone has said in the local anesthetics, acidic pH. What is the significance of local anesthetic acidic pH? Now, you tell me, is lignocaine, alone lignocaine, I'm not talking about your solution, alone lignocaine is an acid or a base? Advantage over, yes, very good. Yes, base, right. What you are using clinically is acid or base? Weak base, very good. All local anesthetic are weak base. Yes, that's the reason why you take any local anesthetic, it will have hydrochloric acid. Why are we adding hydrochloric acid to a base? Yes, everyone is on right note. Lignocaine hydrochloride, bupivacaine hydrochloride, all the things. pKa is a constant, not unionized, not unionized. Why are we adding a base with an acid? Only to improve the cell life, to make it stable, to improve the cell life. Yes, you are right, Dr. Arun Gupta. Right. So the problem with the acidic solutions is whenever we are injecting the acidic solutions, yes, they will have cause acute pain to the patient. That is one of the reason why we add sodium bicarbonate also. When we add sodium bicarbonate, it will not only quicken the onset because more non-ionized format will be there, the pH is increased, and it will reduce the pain on injection. Right. So acidic solutions, when you are injecting, it is very, very painful for the patients. So all local anesthetics, they split into this non-ionized and ionized component. And sodium channel, I have not seen any question previously also. Beautiful sodium channel physiology is there in Miller's anesthesia textbook since 7th edition. Since 7th edition, there are 6 subunits of sodium channel. Right, it's a beautiful description is there. If you are really interested, please go through it, because these are the areas which normal books don't cover it. So these areas which make me, I like this book, Miller's textbook. So that's the reason why I want, if you are, we don't read a standard textbook, or sometimes we manage with some other textbooks where they have not mentioned. So all local anesthetic sodium channel blockade, they block this open and inactive sodium channels. Right. One more question. I think everyone can answer this question. What is the choice of anesthesia for a patient is posted for dental teeth extraction due to dental abscess? Inferior alveolar nerve block or general anesthesia? This question, as it is there in the Miller's anesthesia textbook. General anesthesia, obvious abscess, general anesthesia, exactly, because local anesthetics do not work in acidic medium. Yes, nitrous oxide. What is this mixture of oxygen and nitrous oxide, Dr. Karthik? Oral packing, yes. Oral packing, yes. Entonox, very good. Yeah, everyone knows this answer, so I will not go into the details of this mechanism of action. So very beautiful, this word, exactly, it has been written. And one common clinical scenario, what we encounter with the resistance of local anesthetics in our country. One common scenario, scorpion stinging. Scorpion stinging will cause change in the sodium channel. Yes, scorpion bite or stinging in the early years, which will encounter some local anesthesia resistance will be there. Yes. So that too, it's very, very important. It's there. So there are some reasons for it. Sodium channel itself is marked. So a lot of research is going on in Western world regarding the sodium channel. And once we get this sodium channel exactly, lifelong resistance, yes, lifelong resistance. Because the sodium channel structure itself is changed. As I said you, there are 6 subunits. And the 6th subunit, we know only one subunit of sodium channel. Okay, shall we move to the next question? Yes, the next question is a 1-year-old child was posted for cleft lip surgery under general anesthesia. In the preoperative examination of the patient, the following chest X-ray is noted. Basing on the chest X-ray findings, which of the following is the best suitable induction agent of the state? Look at the chest X-ray and come to a diagnosis. Yes, yes, yes. Obvious. Everyone is tetralogy of palate. The answer is yes. All are right on the same note. It is ketamine. Very good. Maintain systemic. Yes, exactly. So just wanted to highlight this kind of interlinkage. Yes, increased tetralogy of palate, boot-shaped heart, ketamine, because ketamine is the only agent which will maintain the systemic vascular resistance and it will not increase the shunt fraction. That's the reason why, yes, boot-shaped heart. That's the reason why we prefer what we call it as propofol, right? And one more thing which I wanted to highlight from the Miller's anesthesia textbook is ketamine. Yes, one in the chapter of pediatric anesthesia, they have mentioned, I don't know the reason why they have mentioned it, but in case of acute laryngotracheitis or acute epiglottitis, when we are trying to induce the patient, induce the baby for the sleep, they asked us to use halothane. They asked us to use halothane, and they mentioned it clearly. The authors have a personal what we call is preference to use halothane over sevoflurane. The reason being is halothane, the onset is slow. That's the reason why they said you can directly, the patient will not go into apnea or something like that. Yes, sir, in 10th edition also. So in pediatric anesthesia, because most of my patients I practice pediatric, so I referred this chapter first to pediatric anesthesia. They mentioned it clearly that in cases of acute epiglottitis or acute epiglottitis only, if I'm not wrong, not laryngotrachea, croup cases, not acute epiglottitis, we prefer the child should be made all the things, humidified oxygen, the child should not be made irritable, all the things, what they preferred is they said to use halothane. Group also, I think, I don't remember exactly, but they said to prefer halothane. The reason being is because it is slow in onset, so people are trying to prefer this one. Okay, so just have a look at it. If you go by book, it might be halothane, but I generally use sevoflurane only. Yeah, so I don't know which one. So we'll go with examination if they clearly mention, but that much amount of death, I don't know. I don't think they will give you for your examination. Why slow onset is needed? Because most of the times, have you noticed when you are inducing child with sevoflurane, if the child is irritable, what will happen? If you give large doses, he will go into apnea. The moment he goes into apnea, because already epiglottitis is there, it will lead to compromised airway. It's a compromised airway. So I want it to be go slowly, and I want to preserve the normal breathing pattern. So that's the reason why I will prefer, as per author's preference, though halothane is not available in many parts of United States, they still say to use halothane, but I don't find any logical reasoning behind it. But somewhat I found it, so I thought I will add a word here. Okay, that's what I wanted to say. Concept behind fast or slow induction is right to left induction. Here I am talking about group that case. Here group case or acute epiglottitis, I want slower induction. Okay, right? Shall we move to the next question? Right. I think we are on the last one or two questions, I think. Yeah. Identify the true statement regarding the anaphylactic shock. Again, this one, a change there. That's the reason why I added this question. Cough medicines are a potential source of the sensitizing allergens that may predispose to anesthesia-related anaphylaxis. Redman syndrome due to vancomycin is considered as anaphylaxis reaction. Intradermal testing for potential allergens is less sensitive but more specific as compared to skin prick. In a person with egg allergy, avoid propofol. Identify the true statement. C, D, C, G, D. Just waiting for your answer. C, C, D. Okay, just 30 seconds more. C. The answer is, no one has mentioned it correctly. A is the correct answer. No one has mentioned it correctly. A is the correct answer. Now I am happy. Why? Because till now time, all of you are on the same page with me. No, this is the only one where no one has, till now, they have. You might know this answer also. I am not just on a lighter note, I said it. Yes. there is slight change in the anaphylaxis in Miller's 10th edition. So previously in 9th edition, it has mentioned anaphylaxis, the most common cause is antibiotics, because this kind of studies are not done in India. This kind of studies, thank you, Dr. Aruna. Somehow, okay, right. So anaphylaxis, this kind of studies, what is the most common drug which is causing anaphylaxis is not done in India. Whatever the literature it is quoting is from France and United Kingdom. In France and United Kingdom, previously it was muscle relaxants or local anesthetics, but it was clearly mentioned it is antibiotics. Today also it is antibiotics only. Antibiotics only. The second common incidence is muscle relaxants. As per 10th edition of Miller's anesthesia textbook, it is muscle relaxants. The third one is chlorhexidine. This is something new. Previously, I used to sell latex is the second most cause, but I don't know, in Western world, latex usage is decreasing, I think so, but I don't know, but latex is not there. The second is muscle relaxant. The third one is chlorhexidine. The fourth one is local anesthetics. In local anesthetics, that too ester-based local anesthetics, not amide-based local anesthetic. Ester are notorious to cause allergic reactions. Okay, right. Why not it is C, as many of you are reading. So we know it is written, the same line has been, first is antibiotics. Yes, Dr. Pratik. Yes, first is antibiotics, second is muscle relaxants. The third one is chlorhexidine. The fourth one is local anesthetic. Yes, the intradermal testing for potential allergens is more sensitive. Not less sensitive. More sensitive, but not specific. Less sensitive. This is the same line as it is line I picked up from the textbook. Okay, less sensitive. If you are suspecting any allergy, there is no other way rather than to do this intradermal testing. But when you are doing intradermal testing, be cautious. It is not like what we do in the ward. There are so many cases of patients collapsing even with the test dose also. So test dose, whether to do it or not, it's a debatable question. It's debatable question, but as per textbook, intradermal testing is the only way to identify whether you are allergic or not. Right? If you are allergic, then the intradermal testing is the most sensitive but not specific. Right. Then comes why muscle relaxants are prone to show allergic reactions. Which group of muscle relaxants? Again, I want to ask you a question. Steroidal, we can give propofol in egg allergy because allergy is due to albumin. Very good. Right. D is right answer. Atracurium. Right. I want to know which group, not drug. Steroidal group or benzyl isoquinoline group? No, not steroidal. Benzyl isoquinoline, right, Dr. Sheila. The steroidal group includes pancuronium, vecuronium, rocuronium. Benzyl isoquinoline groups includes atracurium, cisatracurium, mivacurium, D-tubocurare. If you go back to the history, it is D-tubocurare. It will cause muscle relaxation. And this are due to, they have proven that in France, they use this cough syrup which contains flocodine. PHLO. We call it as flocodine. Codeine is a cough suppressant. Codeine is a naturally occurring opioid which acts as a cough suppressant, right? So this flocodine, which we use in the cough suppressant, is known to cross react with muscle relaxants, and it is shown to have more incidence in the people who are taking this flocodine cough syrup. This kind of studies are not there in India, but remember, any cough syrup or any cosmetics, what we use during our makeup or any nail polish or all these cosmetic things, they are known to cross react with muscle relaxants and they are going to cause more allergic reactions. That's the reason why. Have you ever noticed we ask the patient to remove all the makeup before coming for a surgery? We will not advise her to make not even lipstick also. Right? We don't know. Most of the times we don't understand the proper reasoning, but this is one of the reasons. So any cosmetics, they interfere with this. They what we call this, they sensitize the muscle relaxants and they will cause this allergic reaction. So codeine. So option A is the true statement out of all. Antibiotics is everyone knows it. Redman syndrome is not considered as an anaphylactic reaction. Why? Redman syndrome is typically due to large doses of vancomycin or fast flushing. It is considered as histamine side effect. It is not due to histamine release. It can be avoided. Can you understand the difference? Red man syndrome can be avoided by slow infusion of vancomycin. But if you are allergic, you cannot avoid it. Can you understand the difference between red man syndrome and why it is not? So someone has said in a person with egg allergy, you can give propofol. No, do not avoid propofol. You can safely use allergies, right? So this is some change which I have noticed. Not, I don't say I have read the book entirely, but yes, these are few changes which I have noticed. So I thought I will put it in a MCQ format so that it will be useful for you. Right now, one more question which I would like to ask you. One drug which has been last 1.5 year back, it has been introduced in 2023, that is called Sugamadex. What is the most common complication of Sugamadex? You can type it in the chat. Sugamadex, most common complication, anaphylaxis. Very good. Yes. What is the dose of Sugamadex? Allergic reaction. What is the dose of Sugamadex? Dose of Sugamadex. Anaphylaxis. Now, 4 mg per kg is normal. Yes, 16, 2 to 18, 16 mg for reversal. And very importantly, Rocuronium plus Sugamadex itself, depending on train of 4. Yes, 2, 4, 16. Very good. 16 mg per kg is immediate reversal. Rocuronium plus Sugamadex combination. Yes, 2 mg, 4 mg you can use. 16 mg is for immediate reversal. The combination itself will elicit the anaphylactic reaction. Have you understood? So that itself is very dangerous. Sugamadex itself is dangerous. Sugamadex plus Rocuronium, in some people, it has been shown to cause fatal anaphylactic reactions. Right? And one more important point which I wanted to highlight is which of the drugs, what we use as muscle relaxants and reversal, will interfere with oral contraceptive pills. Any drug which is interfering with oral contraceptive pills? Yes, again Sugamadex, not Rocuronium. Not Rocuronium, Sugamadex. Why? Because Sugamadex is a cyclodextrin molecule which binds to steroidal hormones as well as steroidal NDMR. That's the reason why we use Sugamadex only for reversal. Yes, cyclodextrin, gamma cyclodextrin molecule. It binds to only Vecuronium and Rocuronium, and this combination will be eliminated through renal route. Right? So less steroidal binding, not only steroidal NDMR, but also for your oral cord. There are so many reports of contraceptive failure after usage. So you have to warn to the patient. And I am expecting this question in your upcoming examination because Sugamadex was introduced in 2023 in our country. Right? So I am expecting this kind of MCQ because Sugamadex interferes with oral contraceptive pills. 7 days extra contraceptive. Other ways you have to advocate for the other extra measures for this contraceptive measures. Right. So this is one thing. And cough syrups and yes, this is intradermal testing. Right. Shall we move to the next question? Yes, the last question. Which of the following inhalational agents contain preservative? Halothane, isoflurane, enflurane, sevoflurane. Yeah, obviously everyone. Yes, right. And again, you know why I kept it? Yes, thymol, right? So why I kept it? This one is the reason being is of late many students have not used halothane, but when we started our post graduation career, it was with halothane only, and we used to use halothane, and it contains thymol as preservative. Halothane has got unique feature that it is the only inhalational or okay, I already said you reacts with breathing circuit. Not only with Dr. Yamini, it reacts with breathing circuit. It reacts with the. It will make that vaporizer dial to be yes methoxyfluorine. Methoxyfluorine out of given option. Methoxyfluorine also doesn't contain. I don't think I have read. This is the only inhalational methoxyfluorine. Methoxyfluorine. I don't think it gets yes dial gets stuck with due to thymol. Okay, I don't think methoxyfluorine. Methoxyfluorine was there in history for a brief period, very brief period. You'll not believe that it is one of the wonderful agent. It was introduced, but it was quickly methoxy also. Yes, yes, but I don't remember exactly. Maybe it might be. I am not very sure. But halothane, because methoxyfluorine I never used it. Halothane it used to be. Methoxyfluorine was in market only for 6 months to 1 year to 2 years maximum. Yes, methoxy also contains some preservative. I don't know. This I recently not concentrated on this methoxyfluoride. Halothane, yes, it has removed because of fluoride toxicity. Right. So halothane is the only inhalational agent which contains preservative. Okay, methoxyfluorine, and also it contains bromide. No other inhalational anesthetics will contain bromide. This is the one agent which contains bromide. It is light sensitive, so we add to make it we add to make it thymol to prolong the shelf life duration. right? So enflurane, again, we are not using due to epileptic nature. Isoflurane is a wonderful agent. Sevoflurane is also a wonderful agent, right? Enflurane is seizures in nature, right? So the isomer of enflurane is isoflurane, what we are using nowadays, right? The only theoretical concern of isoflurane, again, I want to highlight, that is called coronary steal phenomena. It's only theoretical concern. It has not been proven. For any drug of inhalational agent, the agent that is best picked up is sevoflurane. Yes, thymol 0.01%, right? So these are some of the MCQs which, yes, it was nice. I don't know whether I have wasted your time or whether we had a good time or not. So I quickly wanted to revise, sir. We need two more seminars, not just before the examination. I was actually skeptical 2 Sundays to NEET SS regarding green anesthesia. Yeah, I'll add a word, green anesthesia. Yeah, green anesthesia. Of late, the terminology what we are using is clean anesthesia, green anesthesia. We are avoiding desflurane because the only inhalational agent which is causing greenhouse gas effect, that is called desflurane. All the agents will cause, but desflurane has got more, right? Please add NEET SS grant test. Yes, yes, anesthesia. Yes, recently I joined. I made some basic topics in SS. Yes, can we have more sessions depending on the need? Because this kind of questions, why I added is the reason being is I just don't want to give you a FOMO just before the examination. So that's the reason why I kept it very simple options. Because if I add something complicated, just before going to the examination, I personally feel that you should all go with a very positive note, because till now you have done so many rat races in your life, starting from pre-med days, right? So I feel like before going for this examination, now you have got a stage of your life where we need marrow, GT, anesthesia, DM. Yes, these are all the requests that will be taken by the marrow team. Recently, I joined this marrow SS. Last time I was a bit busy with so many applications, classes, and all the things. I do take regularly classes for this PG aspirants. No? So I was busy and I added some basic concepts like introduction. These are all the areas which personally I like. I read a lot of history. I like to read about this gas monitoring, because I am working on this session. I made a monitor, ETCO2 monitor. So I am more into this research, and I made a personal ETCO2 monitor, and I am trying to do this. So I made these concepts of monitoring of gases and all. Why LOX 2% has a label of 21.4, the extra 1.4 mg of hydrochloride. Uh, I don't know, man. I never thought of it. Maybe. No, I don't know. I don't know. Seriously, these are all some questions which I picked up from some of these fancy examiners. How is the progress of your monitor? Yes, my monitor. Yes, right now I'm making a monitor. One monitor came into the market, but I am making one more monitor. I am interested in these monitors and research of all these areas. So ECG, capnography, these are all my core domain areas. So I made this concept of some questions like bronchiectasis, respiratory physiology, some historical aspects, and all these basic concepts. Not much, but basic concepts I have added. But definitely, desflurane, global warming, potential value. People say yes, potential value is there. uh, Potential value is there, but not only this desflurane, people are talking about these syringes, the plastics what we use, they are also contribute to global warming. Why only blame desflurane? But out of all the agents, keeping the cost and all the things, even in kidney centers, recently I spoke to one of my consultant who do a lot of kidney transplants. They say that still they are using sevoflurane. They are using desflurane also, they are using sevoflurane also. So yes, desflurane global value is a potential concern, right? Can you name one inhalational anesthetic which has got analgesic effect? Quickly to wrap up the sessions, which has got analgesic effect. No? Okay, inhalational agent. Nitrous oxide is not an inhalational agent. Xenon doesn't have anything. Nitrous oxide is a gas. I asked an inhalational agent. Don't get confused. Inhalational agent. No, not halothane. I don't think you might have heard this, but older, some crew could, no, 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 no. Older inhalational agent. I'm just giving a guess, giving a clue. No, not ether, not ether, not ether. No inhalational agent will act as trilene, 1 plus Le211. Trilene is the only inhalational agent that was used in the treatment of trigeminal neuralgia. Okay, xenon is an inhalational agent, but it is an ideal gas. It doesn't contain analgesic effect. Okay, so trilene is the inhalational agent which has got this analgesic effect. The usage of xenon is, the MAC values are better. It's a good potent when compared to nitrous oxide. It doesn't have second gas effect. What about chloroform? Chloroform is also doesn't have any analgesic effect. Okay, they are used to deepen the plane. Ether, chloroform. Chloroform was used for Queen Victoria. The reason being is they deepen the planes of anesthesia. They deepen you. They will make you to go into anesthetic stage. So that's the reason why you are getting anesthetized. But per se, trilene has got, it was used in the treatment of trigeminal neuralgia. Right? Then it moved into anesthesia. But again, trilene, one of the very important interaction which examiners are very interested to ask you is trilene plus soda lime. It will produce a very dangerous gas that is called phosgene. Phosgene. Yes, phosgene, right. Yeah, so these are all some of the MCQs because sometimes, yes, trilene lock. Yes, exactly. In the older machines, we used to have this trilene lock. Blood gas solubility and oil gas. Oil, yes, very different. Oil gas solubility is completely different from blood gas solubility. Yes, blood gas solubility, oil gas solubility will tell you because if you look at the history, oil gas solubility will tell me about the potency of the inhalation. That is called as Ostwald oil gas solubility. OSTWALD, Ostwald soil solubility. Right? Blood gas solubility will tell me whether it is the quicker induction or not, whether it is soluble in the blood or not. Right? So oil gas, if you just before the examination, don't try attempt all these things. But all these concepts, beautiful concepts, have been written in the book called Priest Roberts textbook. But just before the examination, don't attempt. My simple request is just before going to the examination, go with a very positive note. Think that you have already did whatever you have to do in your life. You have cleared your MD examination. This is one more rat race where you are. Of late this SS examination, it will not be, not many people will attempt it, but yes, some people, 50% of the students, what I have noticed is they attempt with a half-heartedness. So just be on your senses, think logically in the examination hall, just go and give your best shot. It will work for you. And if not, we'll have this INI set SS also very soon. It's coming on. So definitely you try this NEET SS. Don't take it everything like, very less resources are there to do the MCQs. Yes, one more session. Definitely, I will try to make up one more session. Definitely, it's very interactive and many students are very enthusiastically answering it. And yeah, best of luck. Thank you. All the good, all the best for the students. God bless you all. Wishing you all the very best. Thank you. Thank you very much.